So this will be a kind of a quick overview on how the flow of office-based opioid agonist treatment can occur. And then we can hopefully have time for questions or discussion. So, so this is ASAM's statement on opioid or office-based opioid agonist therapy. DSM-5 classifies opioid use disorder as a chronic and progressive disease, and it's important to recognize that because without our help, physicians, counselors, etc., it can be a fatal disease. And then, you know, the medical community took part in creating the problem of the opioid epidemic, so now it's our responsibility to help treat it. And then there was actually a recent article in the Internal Medicine Journal where it showed that people receiving opioid agonist therapy died less, and this is just from July. So, and then outcomes including less fatalities also include the impact you can make with quality adjusted life years, and it is high due to the fact that many of the patients are young. But as you know, we just had a case with a patient who is 65, but she still has some life. For the purpose of this discussion, we'll just be focusing on buprenorphine as the opioid agonist. There's a common misconception about that is believed by patients, the public, some providers, that you're replacing one drug for another. Well, I mean, that's basically true, but you're creating a difference in their lifestyle instead of the patient spending all of their time locating, obtaining, and using their drug of choice. They can become a functional member of society again, have a better quality of life on opioid agonist therapy. A recommendation for that ASAM makes is that patients must have access to counseling in addition to medication-assisted treatment. That can be therapy, vocational services, 12-step programs, and then also you should consider what level of treatment they need. Would they benefit from a residential program, intensive outpatient, or partial hospitalization? So that's something you need to keep in mind and discuss with the patient. Whenever you assess the patient, a couple things need to be determined. Are they able to do a home induction or a home first dose of Suboxone? Can it be in an outpatient setting, or does it need to be medically supervised? And then, are they pregnant? SAMHSA just came out with opioid use disorder guidelines and recommendations for pregnant women. And for example, Subutex is recommended over Suboxone for pregnant women with opioid use disorder. Do they have Hep C or HIV? Do they need to be tested or treated? Comorbidities including cardiovascular disease. And then do they have a dual diagnosis such as depression, or is it a substance-induced psychiatric problem? Of course, readiness to change is important. And then discuss that with them about relapse prevention and what their needs may be. And then it's also important to note before starting, are they homeless? Do they have a safe home environment? What is their transportation like, insurance, that kind of thing. So we use the COWS, Clinical Opioid Withdrawal Scale, to score the patient to make sure they are in moderate withdrawal prior to initiating the first dose of Suboxone. This is the COWS scale. There's also a scale available for patients themselves that if they are doing a home induction, they can utilize that to help them take the dose at the correct time. So buprenorphine is the partial mu agonist with a higher affinity for the opioid receptor. It has a ceiling effect, meaning that the higher you go, there's not an increased likelihood of having respiratory depression. So it's safe against, or it reduces the risk of respiratory depression and overdose. However, there has been documented cases where concurrent benzodiazepines and Suboxone have caused overdose or respiratory depression. Also, Suboxone does have a high street value, so there is diversion potential. Suboxone costs around $20 in 8 milligram film, which is like $2 to $3 per milligram, whereas oxycodone is around $1 per milligram. So it does have that. So the induction phase is whenever you give the first dose. So this can be done in an outpatient office, in a primary physician's office, or in a specialty clinic. It can also be at home. So basically, we ask patients to abstain from opioid use for 12 to 24 hours, and then they need to be in moderate withdrawal whenever you do initiate the Suboxone. And patients typically know when that is. Otherwise, you can use the COWS scale, and we recommend the patient be at a 12 or above. If you do give it too early, you can throw the patient into fluid withdrawal, which can cause some complications. Prior to the induction, it's important to get a urine drug screen just to make sure that the patient doesn't have methadone or a longer acting opioid, which can mess up the timing of the induction. Liver function testing, pregnancy tests. Again, what is their living situation like? Do they have someone that can come with them and drive them to the appointment, or monitor them at home if necessary? Typically, we have them review and sign a Suboxone agreement. And prior to the induction, we prescribe the medicine or medication to the pharmacy of their choice, and they pick it up and bring it into the appointment. And again, they should arrive in moderate withdrawal. So if it's a medically supervised induction, they'll be in moderate withdrawal. You observe the patient. We typically prescribe the 8 milligram films. And if it's a patient naive to Suboxone, then we have them take half of the 8 milligram film. They put it under their tongue and keep it in their mouth for a full 5 minutes without swallowing for best absorption. And then they can be monitored for a few hours, 1 to 2 hours. And then the patient can take if the patient found relief from that 4 milligram dose, they can take the other half 30 to 60 to 2 hours later to see if their symptoms improve, or if they feel that their symptoms are worsening. And then they can go home, and if they are doing okay, then they don't need to take another 4 milligrams or another half film, but you can give them the option to take another one 4 hours later. And then have the patient check in with you the next day, either phone call, or phone calls usually what we do, or they can come in the next day or two to assess for side effects from the Suboxone, dose adjustments, things like that. And then stabilization phase is the beginning of the Suboxone treatment phase, so in the first couple of weeks or month, and there can be lapses during this time, but it's also a time when you increase or decrease the dose based on the patient's side effects or effectiveness of dose. And then the maintenance phase, when you reach a steady dose and the patient is stable and doing well on that dose. And then during this phase, you can continue a discussion on how long the patient wants to be on Suboxone, or if they'll be on it indefinitely. And then complications include if you are not in moderate withdrawal prior to the first dose, then you can go into Florida withdrawal. Hospitalizations or ED visits have been documented. And then initially there can be return to the drug of choice in the initial phases or months, and then that should be a sign to discuss with the patient what dose they should or need to be on, or what their goals of care are. There is diversion potential during the home-based induction, but their first prescription would only be a minimal amount. And then what's important is that primary care physicians do need to take part in the medication-assisted therapy, just because there is a limited number of addictionologists and addiction psychiatrists available to meet the need that there currently is. So it is not that hard to obtain a waiver. You can do an online course or in-person course, and it can be treated by a primary care provider. So everyone here today is taking the first steps in doing that, and if you let your colleagues know that they can also treat addiction, that would be helpful as well.